Thank you, Senator Kolkhorst and committee members for inviting me to testify before you. I appreciate that. It's a great pleasure that I have to be here, and it's an important opportunity that you've given me. I appreciate that. Mass lockdowns and waiting for a vaccine was an unsustainable model for our citizens from the beginning, and I was determined to help. Allowing patients to go on vents and ECMO goes against without treatment, goes against the Hippocratic Oath, and I was not going to tacitly support this early on. Many roadblocks and misinformation stood in the way. And there's no doubt that COVID-19 has been a great tragedy for the world, our country, and Texas, but it didn't have to be that way. A year ago, it became clear the virus was coming our way, and I have a background in drug development. I patented a drug that eventually made its way through the FDA, and I repurposed 8 other drugs. I started looking, I found like 9 things that might work. I looked at the old coronavirus literature, I found a gout drug that might work, I found a cholesterol drug that might work, and a transplant drug that might work, and many others. And I looked in the literature that very day that I had put the list together, and I found that SARS-CoV-2 was very much treatable with, in tissue culture with hydroxychloroquine, and I was super excited. I was on calls with every night talking to docs around the world, and eventually came down to Seattle, New York, and Louisiana as it came here, and I realized that just attacking the virus wasn't going to work. This disease had many components. There's infection, inflammation, respiratory distress, and blood clots. We had to treat all those things if we were going to be successful, and I realized it very early on. And you heard earlier today somebody say, just before me, there's absolutely no reason why a doctor should let somebody get respiratory distress. The SATs drop to the low 90s. They need to be treated. The C-reactive protein, D dimers are going down. They need to be treated for something for blood clots, aspirin. It's not hard. This is not a hard disease. The hard part is you can't get past the hierarchy telling you not to do these things. This has been the problem. It's not a hard disease. I've treated 286 people. None of them have died, 4 have gone to the hospital. I love all the drugs. Let's say attack the pathogen, the monoclonal antibodies, remdesivir, hydroxychloroquine, azithromycin is also good against that, ivermectin. And what I tell patients is, here's what I tell them. The virus is only replicating for 8 days. And I tell them this. There's cars and car parts. Cars can drive, car parts can't. Viruses can infect. That's for 8 days. Virus particles are all that's left. All they do is inflame. And that's what people are dying from. And so it makes no sense at all to not treat inflammation, respiratory distress, and thromboses early. Wait till patients get to the hospital is insane. So I was very determined not to let that happen. And we end up in a tug of war about attacking the pathogen, which is ridiculous. So as you know, what we've adopted over time is like a multi-drug cocktail, and there's multiple doctors that are involved. We don't need just an infectious disease doctor. He's not the best for inflammation or respiratory distress. We shouldn't be just listening to an infectious disease doctor. That makes no sense. They're not the best at thromboses either. We need a lot of doctors involved. And we need an ophthalmologist probably, because we think we're smart, but it's a whole nother thing. But I got involved, and I was very excited because a lot of patients could not get treatment. And they were calling my office. One was a friend from medical school. His whole family was sick, and I treated him about a year ago. And I knew that what we were doing had to be a multi-drug cocktail. So I gave him hydroxychloroquine, azithromycin, baby aspirin, vitamin D, and he couldn't breathe well. The dad couldn't breathe well, and I gave him an inhaled budesonide. I was so excited, it worked wonderfully, and I got on social media to talk about it, and immediately, about 2 days later, got a letter from the board saying I had to bring all my records, and I was, making untrue claims, and I had to stop, what I was doing. So I decided that I wouldn't stop because I'm very data-driven. I have the data in front of me, and I knew that I would be vindicated because I had lots of information. And so I decided to continue. But many patients, many doctors, many other people were frightened by all this. And because of that, many people didn't get treated, and because of that, many people died. So when we say that the board did a good job, I think in the end they did. But early on, it was very frightening. I was very scared. I felt like my license might get taken away, and I was frightened. Eventually, I think there was probably competing voices, and eventually those competing voices were, through the influence of other people, saw that these were reasonable things that we were doing. But what also happened, it wasn't just in Texas. The NIH said there shouldn't be early treatment. The Harvard Lancet study, for anybody who doesn't know, 2 CV docs from Harvard fabricated a study. Citizen scientists like myself and Dr. McCullough put pressure on them, and eventually it retracted. First time in the history of my 31 years I saw a study retracted. A lot of us stood up and said, this is not true. So, and eventually this actually led to it was basically the nail in the coffin for hydroxychloroquine nationally, and it became, even though it was fabricated, this is what got out in the media, that it was going to kill you. At that time, that was in June, I actually ended up in the White House, and I ended up talking about hydroxychloroquine. I tried to introduce ivermectin, and at the time, the chief of staff said to me, look, I need data. And we couldn't get the data through. We had publications we were trying to get through, and they were slow walking them through national journals. Eventually got published in July, but he said, I can't go forward with anything without data. So we were finding that multiple places we were meeting roadblocks. And again, because of that, early treatment didn't take place, and again, more people died. So I think, as we go through this, I think a government has enormous power, locking down. I have a bunch of papers on lockdowns, masking, school closings. That's what I first went to Washington for. They asked me to come to talk about school closings, shutting down doctors. I mean, it's enormous power, and it's coming between the sanctity of the doctor and the patient relationship for no reason other than, I'm not a political analyst, I don't know, but I know it wasn't right, and a lot of people suffered because of it. And the media bias is continuing. Canceling of scientific voices is real. I've had it happen many times. Freedom of expression is jeopardized every time I present something on YouTube or anything. If I just said what I just said to you, that's infection, inflammation, respiratory distress, and blood clots, and we need a multi-drug cocktail, censored. So I think that as we go forward, the elephant in the room is early treatment works and prevention works. And I would love to see Texas map our own future. That's all I have to say.
Thank you, Doctor. Appreciate, I think the theme here is, making sure that we don't make these mistakes in the future. And there was, pretty strong testimony in the previous witness about the doctor-patient relationship. Senator Campbell has a couple questions.
Thank you, Madam Chair. And I have to admit, I haven't seen this witness for 20 plus years. We both trained at University of Texas Health Science Center, Houston, at the Herman Eye Center. He's an ophthalmologist, so am I. And Rick, it's so good to see you.
Thank you.
I was surprised. It's just good to see you again. You've always been innovative, put patient care first. Thank you for the research that you've done. Thank you for your testimony today. I think you probably, I'm not sure if you were in the room or not whenever I talked to the executive director of the medical board.
I was.
But, it was scary when they first came out. They were pretty egregious in hiding behind the oversight, so I was happy to see at the end how they refrained or restrained or retracted the fear, if you will. So hopefully you are through all the obstacles and you're free and clear of the board.
Well, I thought the board did a good job in the long run.
Yes,
in the short run, they were pretty scary, but I thought in the long run they've been very reasonable, and I give them credit for that.
Exactly, me too. And so that's what I had said. And so anyway, it's good to see you. Yes, I agree. In a crisis, you just don't always know initially. Initially we didn't know anything about the virus, and it took a little bit for us to get our footing. But I think, docs realize that there are some things that can be creative outside the box in practice. And hopefully, as the chairman said, we learned from this and the board, and not making, curative statements is very important. But still treating patients, the whole patient. And as you broke down the pathology, because it's not just a virus like the flu, it's got many components that include inflammation, and those have to be dealt with. So thank you. It's good to see you. Thanks for being here to testify. Thank you, Madam Chair.
Yeah. And I'd like to build upon that. And, pretty public knowledge, our 17-year-old son got COVID this summer, gave it to Jimmy. Jimmy, middle-aged man, very healthy, skinny, I kind of watched this downward spiral, and I just feel really blessed that I had been the chair of Health and Human and knew lots of options. And, my primary care physician and I would have conversations. I'd say, blood oxygen level down to 92, it's time to act. And it was really amazing, through my knowledge of just our work group and different things, sleeping on your stomach, dexamethasone, azithromycin, budesonide. And these are things that I will just say our physician was very receptive to, but almost knew in July that was risky, because of some of the actions and some of the, well, can I prescribe that? It's off label, so forth, so on. And I will tell you that we were able to nip it in the bud in the ambulatory stage, but we were this close to, having to hospitalize Jimmy. And I mean, it was my, gut feeling. We're not winning here. And that's part of the message today is that, I just want doctors to understand, you're smart, you're scientists, you tinker, your patients, and there are pharmaceuticals out there that can really help. And it's different with each person, as we heard in testimony, but I'm really grateful for your unrelenting messaging of there are things that work. Don't let it get to a stage where there's no return. Senator Hall.
Thank you, Madam Chair. And Senator Campbell, I would have introduced you sooner if I had known that, because I've been working with Dr. Russo since last May, I believe. Oh, okay, all right. But anyway, Dr. Russo, thank you for being here today and for what you brought up. And I think what Dr. Campbell was saying and what our chair is saying is that the most important thing right now is that we have our lessons learned from what we went through. There's no question that there was lots of things done wrong and lots of people died unnecessarily. And the worst thing that could possibly happen is for us to go forward not recognizing our history and what did take place, that what you and other doctors recognize could be treated. And hopefully what you had to say there actually is not consistent with what we heard from the Texas Medical Board just a little while ago. They did not aggressively go after it. I heard from too many doctors that had simply tried to treat their patients that were aggressively gone after. Now, maybe they didn't end up losing their license, but just the threat radiates to other doctors to, oops, I best not do this because they may come after me. And that, I think, went a long way in suppressing the other doctors who weren't quite as courageous as what you were and Dr. McCullough and the others, and saying, I'm going to treat my patients anyhow. And so I think that you coming forward and talking, I think it will help. And I just think that that is the most important thing, is that we not repeat this, because I don't think we've seen the last of some kind of pandemic before this is over, and we need to recognize a different way to handle it. So thank you for being here today.
Can I comment on that for a sec?
Yeah, yes.
I was going to say the timeline was the board was pretty aggressive early on, March, April, May, and then they started, I don't know what happened, but they started to get more reasonable right around in June, and then issued a statement. You said about the they called it alternative treatment. Really meant to say was, we can use the drugs off label, but they said alternative treatment, and that statement really helped. But the problem was, a lot of the early treatment alternatives were really beat up in the literature. And I'll give you an example. Harvey Risch, the top epidemiologist probably in the country, has said the chance that hydroxychloroquine doesn't work is 1 in 44 quadrillion. Chance that ivermectin doesn't work is like 1 in 62 trillion, some ridiculous number like that. And despite all that, when the FDA and other people come down on it, it wasn't just the Texas Medical Board. That wouldn't be fair. And as I said, I thought in the end, they actually were much more reasonable. And like I said, whatever voices were there, the calmer voices went out, and I thank them for that. But overall, it was an overhang from not only what was going on here in Texas, but what was going on nationally that made people just too fearful and just said, I don't treat COVID.
Okay, well, thank you. And then that's on the treatment side. There were other things that we did that we need to learn from. We had masks, we had lockdowns, we had business closings. We've looked at the studies, looked at the data. What is your thought on going forward? Should we consider those as tools to be used in the future, or mistakes that we made?
Well, again, I'm
should not be
data-driven.
repeated?
Yeah, I'd be data-driven. Like lockdowns here came out March 5th. Nature, it's the most powerful journal we have. In using 87 different regions of the world, we found no evidence that the number of deaths per million is reduced by lockdowns. I mean, that came out in Nature. It's about a 60-page paper. Came out, this past week. When you talk about masks, the only study that almost RCT comes back this year says randomized control trial, the only one that was done, they didn't work. All right, that was done this past year. State issue mask mandates. Actually, it's kind of interesting because the CDC just came out with a statement. There's no statistical difference. There's a 0.7% difference with state issue mask mandates. 0.7% difference. Despite that, they do recommend people continue to wear a mask, but the data clearly says that that's probably not that helpful. 0.7%, if I told you I'm going to give you a candy bar, 0.7% difference, and I asked you to tell me the difference between those two candy bars, I don't think you could tell me. So I think in general, when we talk about lockdowns, masking, it doesn't make sense. And of course, in pediatrics, in school closures, you can easily see that kids are not super spreaders is the end of the statement. But in 5 different studies, 1 from Switzerland, 2 from China, 1 in France, 1 in Australia, only 1 adult transmission that I know of took place from a child to an adult. So kids don't spread. We shouldn't lock down schools. I mean, the whole picture is not data-driven, and I find that to be a problem.
Okay. Thank you very much.
Thank you,
Madam Chair.
Dr. Urso. Appreciate you being here.
Thank you, everyone. I really, really appreciate it.
Yeah, important messages. Chair calls Dr. Peter McCullough. Welcome, Dr. McCullough. I know that you are also involved in some of our schools of medicine. And so if you would state your name for the record and...
Good afternoon. I'm Dr. Peter McCullough, and I'm an internist and cardiologist and professor of medicine at Texas A&M University School of Medicine. I'm on the Baylor Dallas campus, and I've been integrally involved in the response to COVID-19. The opinions I'll express are those of my own and not necessarily those of my institution. I can tell you that in my field, I'm an academic doctor. I see patients, but I'm very involved in research. I'm an editor of 2 major journals. In my field, I'm the most published person in my field, which deals with the heart and the kidneys in the world in history. And when COVID-19 hit, I saw it as our medical Super Bowl. And there were going to be doctors like Dr. Urso coming out of wherever they worked to face the virus. And there were doctors in the hospital that just had to receive the virus. And then there were those who headed for the sidelines, and then there were those that were detractors against the pandemic. And so as I started to survey the literature, I had patients with heart and lung disease who needed urgent treatment. And I refused to let an illness, which lasted for 2 weeks at home, before they got sick enough to be hospitalized, I refused to let a patient languish at home with no treatment and then be hospitalized when it was too late. It was obvious. That was obvious in April that was the case. So I used the best tools or drugs available at the time, and these are appropriately prescribed off-label. Remember, a label is an advertising label. A label isn't a scientific document. Sure, it's an appropriately prescribed off-label use of conventional medicine to treat an illness. And in May, I put together a team of doctors because the group that was facing the pandemic to the greatest degree was in Milan, Italy, so most of them were in the Corrical Italian Research Network. We summarized all we knew about the available drugs, and we published our findings in the August 8th issue of the American Journal of Medicine. And the title of that paper was The Pathophysiologic Basis and Rationale for Early Ambulatory Treatment. And it had a premise. There's 2 bad outcomes to COVID-19, hospitalization and death. The second premise, if we don't do something before the hospitalization, we can never stop it. We can never stop it. And I have to tell you, and I was the lead author in that paper, but we had dozens of authors from Italy, India, UCLA, Emory. We had the best institutions in the United States. I can tell you the interesting thing was there was 50,000 papers in the peer-reviewed literature on COVID. Not a single one told a doctor how to treat it. Not a single one. When does that happen? I was absolutely stunned. And when this paper was published in the American Journal of Medicine, it became a lightning rod. Oh my gosh, it became the most cited paper in basically all of medicine at that time. The world started, and boy, the world started knocking on my door. And I said, oh my Lord, I just can't believe what became untapped. And I had never been on social media before. And my daughter, who was home from law school, I was talking to her about it. She said, well, why don't you make a YouTube video? So I made a YouTube video with 4 slides from the paper. This is a peer-reviewed paper published in one of the best medical journals in the world. 4 slides. I even wore a tie and a suit, and she showed me how to record it in PowerPoint, and I posted it on YouTube. It went absolutely viral. And within about a week, YouTube said, you violated the terms of the community. And that's when Senator Johnson's office got involved in Washington and said, oh my gosh, this is important scientific information to help patients in the middle of this crisis, and social media is striking it down. Based on what authority? Well, one thing led to another, and I became the lead witness for the U.S. Senate testimony on November 19th, 2020. And the reason why there was Senate testimony is because there was a near total block on any information of treatment to patients. A near total block. And so what had happened over time is that we had gotten into a cycle in America of no information on treatment. Patients actually think that the virus is untreatable. And so what happens is they go out to get a diagnosis. Now, I'm a COVID survivor. My wife in the galley is a COVID survivor. My father in a nursing home is a COVID survivor. You get handed a diagnostic test. It says, here, you're COVID positive. Go home. Is there any treatment? No. Is there any resources I can call? No. Any referral lines, hotlines? No. Any research hotlines? No. That's the standard of care in the United States. And if we go to any one of our testing centers today in Texas, I bet that's the standard of care. I bet that's the standard of care. No wonder we have had 45,000 deaths in Texas. The average person in Texas thinks there's no treatment. They honestly think there's no treatment. They don't even know about these EUA antibodies. You heard from a 90-year-old gentleman who got bamlanivimab. Terrific. Where's the focus? There's such a focus on the vaccine. Where's the focus on people sick right now? This committee ought to know where all these monoclonal antibodies are. They ought to know where all the treatment protocols are. They ought to have a list of the treatment centers in Texas that actually treat patients with COVID-19. So I led the initiative. The second paper was published in a dedicated issue of Reviews in Cardiovascular Medicine. Now I had 57 authors, including Dr. Urso, Dr. Emmanuel, lead doctors in Houston, San Antonio, all over. And it was another worldwide paper, and now we have it updated, integrated. So yes, we use drugs to affect viral replication. The antibodies are terrific. We can use intracellular anti-infectives in that box. We use corticosteroids and inflammatory drugs. The best anti-inflammatory drug is colchicine. You've probably never heard about it. In the largest, highest quality randomized trial, over 4,000 patients, double-blind randomized placebo-controlled trial, there's a 50% reduction in mortality. No word of it. None. Complete block to anybody, colchicine. How can that be? How can that be? And then the most deadly part of the viral infection is thrombosis. So I have always treated my patients with something to treat the virus, something to treat the inflammation, and something to treat thrombosis, just as Dr. Urso had. And I have very, very sick patients, and I've lost 2. But I have to tell you, what has gone on has been beyond belief. How many of you have turned on a local news station or a national cable news station and ever gotten an update on treatment at home? How many of you have ever gotten a single word about what to do when you get handed the diagnosis of COVID-19? No wonder. That is a complete and total failure at every level. Okay, let's take the White House. How come we didn't have a panel of doctors assigned to put all their efforts and stop these hospitalizations? Why don't we have doctors who actually treated patients get together in a group and every week give us an update? Why didn't we have that? Why didn't we have that at the state level? 0. Why don't we have any reports about how many patients were treated and spared hospitalizations? From all the, I listened to 6 hours of testimony today. Zero. Zero. We have a complete and total blank spot on treatment. It is a blanking phenomenon. At least in the United States, there's some heroes. Now, the American Society of Physicians and Surgeons took the lead. They're the group. They've identified 35 treatment centers in Texas. They know who they are. They have emergency hotlines. They helped Dr. Hall put together this very brief pamphlet, but there's more an extensive one. We can pass it around to everyone that at least gives people half a chance to find out about information, okay? This is a complete and total travesty to have a fatal disease and not treat it. Now, the National Institutes of Health and the Infectious Disease Society of America started putting out guidelines in the treatment of COVID-19, and to this date, they nearly exclusively deal with the hospitalized patient. The two papers that I have published as the lead author and supported by wonderful people by Dr. Urso are the only publications in the peer-reviewed literature that tell doctors how to treat COVID-19 as an outpatient based on the support of scientific information. The only two. The Home Treatment Guide by the American Physicians and Surgeons is the only source of information available to patients on how to treat COVID-19 at home. The only source. So what can be done right here, right now? There's going to be more people that die in Texas, and it's an absolute tragedy. How about tomorrow? Let's have a law that says there's not a single result given out without a treatment guide and without a hotline of how to get into research. Let's put a staffer on this and find out all the research available in Texas, and let's not have a single person go home with a test result with their fatal diagnosis, sitting at home, going into 2 weeks of despair before they succumb to hospitalization and death. It is unimaginable in America that we can have such a complete and total blind spot. I blame the doctors for not stepping up. Where was the medical society stepping up and putting effort on this? How about from the federal and state agencies? There never was a single bit of group collaborative effort to stop the hospitalizations. Nobody even kind of thought about it. Bob Hall had me on a teleconference in April or May, and we're like, wait a minute, how come, where's UT Southwestern? I'm a graduate of UT Southwestern. Where's A&M? Where's the rest of the universities? How come we're not stopping this? How come we are not stopping this? But it gets worse, because in the paper I published in December of 2020, you know what he did? I had a terrific doctor from Brazil. We went through country by country by country and just asked the question, what are other countries doing? When was the last time you turned on the news and ever got a window to the outside world? When did you ever get an update about how the rest of the world is handling COVID? Never. What's happened in this pandemic is the world is closed in on us. There's only one doctor whose face is on TV now. One. Not a panel. Doctors, we always work in groups. We always have different opinions. There's not a single media doctor on TV who's ever treated a COVID patient. Not a single one. There's not a single person in the White House task force has ever treated a patient. Why don't we do something bold? Why don't we put together a panel of doctors that have actually treated outpatients with COVID-19 and get them together for a meeting? And why don't we exchange ideas? And why don't we say how we can finish the pandemic strongly? Isn't it amazing? Think about this. Think about the complete and total blind spot. So what happened? I can tell you what happened. What happened in around May, it became known that the virus was going to be amenable to a vaccine. All efforts on treatment were dropped. The National Institutes of Health actually had a multi-drug program. They dropped it after 20 patients, said we can't find the patients. The most disingenuous announcement of all time. And then Warp Speed went full tilt for vaccine development. And there was a silencing of any information on treatment. Any. Silencing. Scrubbed from Twitter, YouTube. Can't get papers published on this. We can't even get information out in our own medical literature on this. There's been a complete scrubbing. So this program has been one of try to reduce the spread of the virus and wait for a vaccine. And when we vaccinate, all efforts have to be on vaccination. And probably if I had 4 hours of vaccination on here. Think about it as we sit here today, the calculations in Texas on herd immunity. The calculations are we're at 80% herd immunity right now with no vaccine effect, 80%. And more people are developing COVID today. They're going to become immune. People who develop COVID have complete and durable immunity. And a very important principle, complete and durable. You can't beat natural immunity. You can't vaccinate on top of it and make it better. There's no scientific, clinical, or safety rationale for ever vaccinating a COVID recovered patient. There's no rationale for ever testing a COVID recovered patient. My wife and I are COVID recovered. Why do we go through the testing outside? There's absolutely no rationale. I'd encourage this committee to actually look at what's being done and ask, is there any rationale? Is there any rationale for anything? Listen, there's plenty of COVID recovered patients. Let them forego the vaccine and let people who are clamoring for it get it. But at 80% herd immunity, in the vaccine trials, fewer than 1% in the vaccine and the placebo actually get COVID, fewer than 1%. The vaccine's going to have a 1% public health impact. That's what the data says. It's not going to save us. We're already 80% herd immune. If we're strategically targeted, we can actually close out the pandemic very well with the vaccine, but strategically targeted. People under 50 who fundamentally have no health risks, there's no scientific rationale for them to ever become vaccinated. There's no scientific rationale. One of the mistakes I heard today as a rationale for vaccination is asymptomatic spread, and I want you to be very clear about this. My opinion is there is a low degree, if any, of asymptomatic spread. Sick person gives it to sick person. The Chinese have published a study, British Medical Journal, 11 million people. They're trying to find asymptomatic spread. You can't find it. And that's been one of important pieces of misinformation. When Senator Hall called a conference call of what should we do in the Capitol when we reopened, I said, you know what? You know what we do at Baylor? You walk in and they zap your temperature, you got a temperature check and go in. Do we test everybody who walks into Baylor Hospital? No. Are they a lot sicker than everybody in this room? You better believe it. So why would we do something here at the Capitol that has absolutely positively no scientific rationale and then do it in this context? So my testimony as I sit here today is COVID-19 has always been a treatable illness. A very large study from McKinney, Texas, another one from New York City, show that when doctors treat patients early who are over age 50 with medical problems with a sequenced multi-drug approach with the available drugs, 4 to 6 drugs that are available to them, now the monoclonal antibodies are better, there's an 85% reduction in hospitalizations and death. 85%. 85%. I want you to remember that number, 85%. We have over 500,000 deaths in the United States. The preventable fraction could have been as high as 85% if our pandemic response would have been laser focused on the problem, the sick patient right in front of us. We were focused over here and focused over there and focused on masks and what have you. Laser focused, sick patient, treat them. We lost focus on the most fundamental thing.
Dr.
That's my testimony.
Yeah, thank you. I can tell how passionate you are and certainly have been a leader in talking about preventive protocols and also the ambulatory stage. And I do think that has been missing, and it's been a concern because COVID-19 is going to be with us, right? I mean, it's, I hope we're at 80% herd immunity. I don't know yet. I'll read your papers, but I appreciate that, and the message is that there are drugs out there that work. There are therapies out there that work.
But no single one works alone. And so the dismissive mistake was to do a very small study. Oh, we studied 200 patients, and we used ivermectin, hydroxychloroquine, and it didn't work. That's like cancer and picking one drug and saying, oh, it doesn't reduce cancer mortality. We never do that in cancer. We never did that in AIDS. We don't do it in hepatitis C. What we look for is signals of benefit and acceptable safety, and then we combine them. And that's all we've done. So, but this independent declaration, drug by drug, that drugs don't work, has been, and that's on us. That's been our medical house. That's been a giant error that we've made on our side. We never should have expected single drugs to reduce mortality, but drugs in combination against a fatal and viral infection, we should have.
This entire session is learn from lessons. I know we're running short on time. Senator Hall, you have one question or?
Real quick, I'd asked the question earlier when Dr. Hellestat was here about the idea that fits in with what you've talked about, is that when we test someone, rather than just give them, yep, you're positive, you're negative, be on your way, that we at least provide them information of what we know out there can be used, not trying to play the role of doctor out there. Do you agree with Dr. Hellestat's interpretation that that should not be done because it's setting up a doctor-patient relationship and simply informing people or providing with over-the-counter drugs that so that we could possibly have the early treatment for these folks rather than wait till they show up in the hospital?
We could at least have a physician group approved a guide. The AAPS guide has been used in over 500,000 cases in the United States. In fact, the early treatment is probably what prevented us from overflowing the hospitals in the last quarter of the year. When I testified, I said, listen, we're on track, and I was very convinced of this, we're on track of overflowing our hospitals. Our break point was 135,000 in the hospitals in the United States. We hit 128. Now, the curve started going down long before the vaccine. So I can tell you, herd immunity, long before the vaccine showed up, started to go down. But the early treatment kicked up. Ivermectin use skyrocketed. Hydroxychloroquine, monoclonal antibodies, as much as we can push them. Sadly, the monoclonal antibodies are still sitting on the shelf in a lot of places. But committees like this ought to be saying, listen, where are those monoclonal antibodies? Are we stocking them at the nursing home? What are the big nursing home chains? What are the big urgent care chains in Texas? And what are they doing? What are their early treatment protocols? These are blank spots. I bet nobody here has even thought about this. This is really low-hanging fruit that we can tackle. The bottom line is a lot of doctors have checked out. And when patients call them, they say, I don't treat COVID. And when I asked those doctors, I said, you don't treat COVID? How come? They go, well, there's no treatment. I said, but do you call them 2 days later to see how they're doing? No. So what's that? That's not I don't treat COVID. That's I don't care anymore. That's a loss of compassion. So we have a crisis of compassion in our country in the medical field. That's in our house right now. But for every doctor that's ever told a patient that they don't treat COVID, okay, but then they call them 2 days later and help them get oxygen or see how they're doing? If the answer is no, that's the Hippocratic Oath going out. And that's on us. And I'm telling you, we have a real self-check to do in the House of Medicine.
Yep. Well, Dr. McCullough, thank you. I think you've given us some challenges and some ideas again about what we could do going forward. And you've asked some questions that I couldn't answer, so thank you. You've made me better today, and I think you've made the committee better. Look forward to working with you in the future.
Thank you.